Welcome back. I am Adam Thompson, and this is part 2 of the 12-lead EKG comprehensive course. If you remember, I said that there's a 6-step process to interpreting 12-lead EKGs that we're going to follow. Step 1 is rhythm interpretation, and there's already an EKG course for learning how to interpret rhythm and identify and recognize different dysrhythmias. If you aren't familiar with rhythm interpretation, go and do that, then come back to this. Then step 2 is axis determination, and there is also an ECG axis tutorial that you can do to learn how to identify the different EKG axes. And then step 3 is intervals, and step 4 is morphologies. So that's where we are at. We're going to learn how to identify different intervals and morphologies on the 12-lead EKG. Before we do, I want to give you another resource. ECGpedia.org. It's been around for a little while. It's a pretty nice little website. It's really clean. It's like the Wikipedia for EKGs, hence the name. They do use a different process for interpreting 12-lead EKGs than I use or Tom Bouthillet uses, but it's still a process. It's still methodical, and it would still work. If that's the process that you so prefer, then go ahead and use that process. Nobody's going to tell you which method is better. I like less steps, though, so that's why I like the 6-step. Theirs is 7 plus 2, and I've seen 10-step processes and so on and so forth, so I'm going to stick with the 6 steps. It seems easier for me. And here is that 6-step process. So, like I said before, rate and rhythm, you got to know how to do that, and you got to know how to do your axis determination, and then we'll get here to intervals and morphology. That's what I'm going to talk about in this lesson. Understanding intervals and morphologies will help you with all of these things. Bundle branch block identification, Wolff-Parkinson-White syndrome, and recognizing that's a type of an accessory pathway that can pre-excite, cause a re-entry tachycardia. It's very interesting. Chamber enlargement, hyperkalemia or hypokalemia, hypothermia, long QT syndrome, which is lethal. Remember that. And digitalis toxicity. All of these things can present with changes in the intervals or morphology. So let's start pretty basic. Here's a P wave. Okay, in your P wave, normal height is going to be less than 2.5 millimeters. Okay, each small box on an EKG is 1 millimeter. So your P wave should be shorter than 2.5 of those. All right? The normal width is 0.10 seconds, which we know is 100 milliseconds, which it should be less than that, right? So less than 100 milliseconds. And each small box, again, is 40 milliseconds, so 2.5 of those would be 100. So that's the going length, 2.5 small boxes. So you want the P wave to be less than 2.5 small boxes in height and less than 2.5 small boxes in length, or width, however you'd like to look at it. Now the P wave can have a different presentation or morphology based on where atrial depolarization is being originated, okay? So in general, in a healthy person, your atrial depolarization is generated in the right atrium at something called the SA node, the sinoatrial node, right? We've all learned about that. Okay, let's say it's right about there. Okay, and you're going to depolarize the atria in this direction, okay? And most of our monitoring leads, okay, are going to be looking up at this, from this direction, okay? So lead 2 looks from that direction. AVF looks from right here. We know lead 1 looks from right here, okay? So if we're looking from this direction, and we know because we did the axis tutorial that any time the depolarization wave is moving in the direction towards the positive electrode of a lead, you'll get a nice upright complex, and that's why usually your P waves will be positive. However, let's say, let's get rid of all this. Do this a little quicker here. Let's say the the atria for some reason, let's say you had a junctional rhythm, okay, and the atria will be being depolarized in this direction. That's totally different, right? It's backwards. Well, then you might get something like this, a negative P wave, because it's going away from the positive electrode of those monitoring leads. So you get a negative P wave in some of the leads. Okay, so keep that in mind, that the P wave morphology will change based on wherever your pacemaker is. So normally, we know our pacemaker is the SA node, but it could be the AV junction, it could be some other area in either the right or left atrium. So keep that in mind. P wave morphology can also change based on atrial enlargement, the size of the atrium, the thickening of that myocardium around those top chambers of the heart, okay? And how might it change? Well, let's say we're looking at a normal P wave. A normal P wave takes both the polarization of both atria, the right and left, and kind of combines it into this nice single, hump, if you will, or wave. And that's got both atrium or atria in there. When you start to have one of the atriums get larger, you can actually see atrial polarization of both atria. Well, no, it sounds kind of confusing, but let's look here. So with P mitral, okay, P mitral is a way to identify left atrial enlargement. And how I remember that is it kind of makes the shape of an M for mitral, all right? And you might see this in lead 2 or any of the other monitoring leads, and it's basically a notched P wave, which is not normal. And what you're seeing is the right atrium depolarize and then the left atrium depolarize, because the thickening of the left atrium causes it to take a little bit longer to depolarize. So now you're going to see separation. And in V1, you might see a biphasic P wave that is deeper than it is tall. It's common to see biphasic P waves in V1, but usually they're not too deep. But if they start to get pretty deep, that means that you've got strong vectors in the left atrium pulling it over from the enlargement of the left atrium. So here, looking at this 12 lead EKG, let's look for those things we were just talking about. You might not see the P mitral. It's kind of, it doesn't stand out too much here, but you can sort of see it there in lead 2. But you can certainly tell that in V1, the P wave is deeper than it is tall. So we have an indication, however, it's not conclusive. It's an indication that you have a left atrial enlargement here. And similarly, we can identify if the right atrium's enlarged, or if there's an indication that the right atrium's enlarged. And that might look like a very tall P wave, okay? Taller P waves indicate that the right atrium has, a thickening of the muscle. It might be enlarged, all right? So it could be peaked or have a larger hump or wave. And you might be wondering, how does this help us at all? What does this tell us about? Well, I'll just give you one example. Who gets cardiomegaly? Who gets enlarged chambers? Your CHF patients, right? CHF patients, it's very pathognomic for them to get cardiomegaly, LVH, RVH, and we know COPDers can develop cor pulmonale and get right ventricular hypertrophy. And guess what? If those ventricles get enlarged, the atria also get enlarged. The whole heart becomes enlarged eventually, and that is where heart failure comes from. That is cardiomegaly. So it is important, and it does help you. And you may be, if you don't know about this, then you may be wondering, well, why does the P wave look like this? And then it concerns you because you might be thinking it's some funky dysrhythmia, when all along it was just something that the patient chronically has due to something like CHF. So that's why it's helpful. In between the right and the left atrium, there's actually intranodal, or I should say intraatrial pathways that kind of bring the conduction over from the right atrium to the left atrium, and normal conduction. And it makes it fast conduction too. Whenever you don't have an intranodal pathway or intraatrial pathway or a pathway for conduction, then the cells actually have to communicate from one cell to the next in a much slower way, and that can create some sort of delay. And delays on a 1280 kg are seen usually by width, but also could be changes in morphology as well. And if you're looking in V1 and you see a P wave that's biphasic, but it's taller than it is deep, okay, it's pretty tall, this could be a delay in Bachmann's bundle. Again, it's not certain. I'm not saying it's absolutely an atrial conduction delay, but this is indicative of that. So this is a good place to take a nice pause before doing the next video. I'm trying to keep these videos relatively short, so they're kind of snack size. I don't want you to have to sit down and sit through too much at once. Kind of review them, look at some EKGs. Even Google left atrial enlargement, some things we've already talked about, and see if you can recognize it on the different EKGs that are out there before moving on to the next lesson. We're going to get more into intervals and morphologies and all that stuff. I just wanted to give you a chance. If you can always go back and watch previous videos or click here to see the next.